Onc Live Insights is a video editorial program produced by Onc Live.
So at some point in the management of these aggressive thyroid cancer patients, we're going to decide that radioactive iodine is no longer effective, that I can't use specific directed therapies like external beam radiation anymore or surgery to kind of control their disease, and we're going to need to be moving toward one of these novel FDA-approved drugs or one of our new treatment options that we have. And honestly, this is one of the most difficult decisions we really make, because these patients often have disease that's relatively slow growing. It's getting a little bit bigger every 6 months. If it's rapidly getting bigger, that's easy. We know radioactive iodine is done, and we move them to the oncologist to treat with the medicine. Very often they're very slowly progressive, and we're trying to balance when's the right time to intervene and do something. That we know these drugs have some side effects, and so we're going to put some side effects on the patients, but at the same time we get the benefit of stopping the disease from growing. In our center, what I typically do is I refer the patient to the oncologist about a year before I think we need them. I love that overlap for a year. When the patients are totally stable, they stay with me because we know we're not going to be on one of their drugs. But if we have progressive disease and I'm looking a year down the road and I think maybe a year from now we're going to be headed toward really starting one of those medicines, I'd love for the patient to meet the oncologist and share the patient with me for a year. The oncologist gets to know the patient gets to know the oncologist, and the oncologist helps me make a decision. Over that 6-month visit and 1-year visit, do we both think it's time to start something? If it is time to start something, what would be the most appropriate drug to use? The other thing we do is I don't personally administer the drugs. I could, but I don't. In our setting, I've got wonderful oncologists to work with. And so we have a discussion with the patient at the end of that year, whenever that transition is, where we say, okay, the captain of the ship is now the oncologist. He's going to be the one, she, writing the medicines, writing the drugs, doing the follow-up scans. I still want you to come see me, because many of these drugs affect thyroid function tests, they affect calcium, so it's helpful to have an endocrinologist as part of the team. I think it's also very educational for the endocrinologist to watch their patients on these drugs and see what the side effects are or aren't and learn about these things. So we co-manage these together, but at the point it's time to actually start the medicines, we ship who's going to be the captain of the ship. Patients seem to like that because it can be really confusing who's in charge. They've been seeing me for years, they know me for years, I've been making all the decisions, so I think it's important to have that decision. I will tell you, at all the panel discussions that we have, patients are always presented to us that are like right close to that tipping point. And I'm still not certain in the United States we all agree exactly where that tipping point is. I think the oncologists tend to be a little more aggressive than I am. As an endocrinologist, I tend to be a little less aggressive. The right place is somewhere between us, which is why I think it's fantastic to have these patients have that perspective of an endocrinologist that knows the disease, of an oncologist that knows about cancer and oncology and these drugs, and that sort of triangle of a team help the patient understand when the benefits of starting one of these medications outweighs the risk. And as a team, when do we think it's important to sort of cross that tipping point and move in that direction?
So people did not refer patients with thyroid cancer to the medical oncologist because the assumption had been that there's really no agents that we can offer these patients for treatment. Now, in the past 5 years, this really has changed tremendously, where now we have 2 drugs available for radioactive iodine thyroid cancer, differentiated type, and also we have 2 other drugs approved for medullary carcinoma of the thyroid. So in the past 5 years, we've actually seen 4 drugs become available for thyroid cancer. Now, it is not readily apparent to people who don't see a lot of thyroid cancers when is really the appropriate time to start treatment with these agents. Now, these agents obviously have side effects, they have risks attached to them, and the medical oncologists are the most really familiar with these agents because obviously they deal with chemotherapy and they deal with tyrosine kinase in different settings. My suggestion is obviously when you're dealing with patients with metastatic disease, even if that patient has well-controlled disease that is quite indolent and it's not changing on scans, I would recommend that this patient have a conversation with a medical oncologist to really introduce the concept of tyrosine kinase therapy and discuss with the patient on what would be the appropriate time and what we would be looking for in that patient to initiate therapy. Because many of those decisions are not clear even to people who deal with this on a regular basis. And because of the complexity of these treatments and the number of side effects that can be encountered, I would recommend that any patient with number one, aggressive thyroid cancer by histology be referred to a medical oncologist for a conversation. And definitely patients who have metastatic disease, for those patients to meet with a medical oncologist to discuss treatment options. Another area where we are also seeing some changes, and that's a completely new area for everybody, is this concept of adjuvant therapy. There are clinical trials right now that are asking a question of, should we treat patients who have aggressive thyroid cancer but no metastatic disease, meaning your patients who has large thyroid cancer that's been resected, that's been removed, that had a neck dissection, and now there's no evidence of disease. Patients is cancer-free by imaging and during the operation. Some of the clinical trials ongoing currently are asking a question of adjuvant therapy. Would a patient like this, that does not have evidence of metastatic disease or locally recurrent disease, benefit from what we call adjuvant therapy? And that adjuvant therapy is usually a tyrosine kinase inhibitor. So that's a completely novel idea and concept in thyroid cancer that was not present a few years ago. And obviously, clinical trials are not necessarily readily available to everybody, but they're often available in a medical oncology setting. And I would encourage endocrinologists and head and neck surgeons, because also those deal with thyroid cancer on a regular basis, to really talk to their medical oncologist, refer the patients early on for at least a discussion and a conversation with that patient about the possible benefit of tyrosine kinase treatment. So the idea of referring a patient to an academic center or a center of excellence, it is not necessary to do that to treat patients, because as I mentioned, we do have drugs available now for everyone to use. We have 2 drugs. But referring to an academic center does become important when you have used these agents, for example, and you're looking for the next step for that patient. So clinical trial referral, that would be one venue to refer to an academic center. And also, again, for genomic profiling, which is commonly done in academic centers to look for, again, alterations or what we call druggable mutations, meaning mutations that we can target with a new drug.
I think it's reasonable to have an endocrinologist refer a patient to medical oncology when that patient is first being treated with radioactive iodine for distant metastatic disease. We feel that it's helpful to involve a multidisciplinary tumor board to make decisions about when a patient should be treated with radioactive iodine versus when they should begin treatment with an oral tyrosine kinase inhibitor.